Dr. Alexei, can you hear me?
Yeah, I hear you. Hello,
Okay.
Mr. Shintaro.
Hello.
One moment, I will switch on video.
Okay. Dr. Alexei, can you hear me?
Yeah, I hear you very clear. I hear you. Yeah. Hello,
Okay.
Mr. Shintaro.
Hello. Please wait.
One moment, I will switch on video.
Okay. Dr. Alexei, can you hear me?
Yeah, I hear you. I hear you.
Okay, thank you. Testing 1, 2. Okay. So you're connected from your home?
Yeah, I connected from my home. Is it possible?
Yes, no problem.
I will switch off the microphone.
Okay, thank you.
Oh, hello, colleagues.
Hello, Dr. Vladimir. Can you hear me?
Shintaro,
Hello.
is picture good? And what is about sound?
Image and sound is very clear.
Thank you.
Okay, thank you for connecting early.
Okay, I turn off the microphone.
Okay, thank you.
Thank you.
see.
Brudenko, can you hear me? Boris, can you hear me?
Yeah, I do. We can
Okay,
hear you.
thank you.
Thank you.
Thank you very much.先生、聞こえますでしょうか？
はい。私。
柏田先生。
はい、聞こえます。先生しか聞こえなかったんで、私の名前だったんですね。
すみません、柏田先生、ありがとうございます。
はい、
本日よろしくお
よろ
願いします。
しくお願いします。
Hello, Dr. Colin.
Okay, hello everyone. This is Dr. Tomohiko Moriyama from Kyushu University Hospital. Thank you for joining us today under this very difficult situation on COVID-19. But I'm really happy to know everybody looks very good. Okay, so today, same as before, we hold this session on Zoom. So most of the participants joined this session personally, not by institutions. So I'd like to call in the name of some people to check the microphone and the camera. So first, I'd like to invite Dr. Andrei Korobanov from Yaroslavl Clinical Radio Hospital. No, sorry. Then okay, Vladivostok Clinical Railway Hospital. Dr. Konstantin?
Good evening, everyone. We're also very glad to see you healthy. So we are glad that such condition in our world improves. And I hope that some days we will meet offline.
Okay, thanks. Okay, then next is Nizhny. Dr. Mitrakov.
Hello, dear colleagues. We are so glad to see you and in this conference, and we want to say thank you very much for the invitation, and thank you. Nice to see you.
Thanks a lot. Okay, next is the Russian National Research Medical University. No, okay. Then the National Center of Cardiology and Internal Medicine from Kyrgyzstan.
Good day, colleagues. We are happy to see you today from Kyrgyzstan.
Hi, Tarugan. Nice to meet you again.
Nice to meet you.
Okay, next is in the Juntendo University, Dr. Professor Takashi Yao.
Hello, everybody. I'm glad to see you. And I'm in my room in university, but the background picture is a Japanese castle in my hometown, which was taken in front of my birthplace house. Thank you.
Okay, thanks a lot. Okay, next is Osaka International Cancer Institute, Dr. Uedo and Kanesaka Sensei. Right?
Hello, this is Osaka. And I and Satoki Shishiro is now in a conference room, but this time I invited Ryu Ishihara, who was in charge of Japanese Endoscopy Society guideline for esophageal cancer. So I think you can see Ryu on the screen. So I think he can give some comment. Thank you.
Okay, thanks a lot for inviting Dr. Ryu Ishihara. Okay, so the next is in Burdenko Hospital, Moscow. Dr. Sokolov.
Thank you very much for invitation. We we are glad to see all participants. Thank you very much.
Okay, thank you for joining us. Okay, next is the Swimming Pool Expert Endoscopy Center, Dr. Alexei.
Very nice to meet you all. Thank you for invitation. I wish everyone good health and today's very good meeting. Thank you.
Okay, thanks a lot. Okay, next, then the Kinda University, Professor Kashida.
Yeah, nice to meet you all. I have met many Russian doctors online because I have attended 3 meetings in Russia online so far during the last 1 year. Today, I'm on a holiday. It's a paid leave from the hospital, so I'm staying at my house today.
Okay, thank you, Dr. Kashida. Okay, and today the 4 doctors endoscopists are joining from Kyushu University Hospital. So then each of us will introduce ourselves briefly. Dr. Esaki, would you introduce yourself first?
Hello, my name is Mitsuru Esaki. I'm very happy to attend this meeting.
Hi everyone, my name is Yoichiro Ono. I'm from Fukuoka University Chikushi Hospital. Nice to meet you. I'm glad you are.
Hello everyone, nice to see you again on the internet. So as he told you, I accompanied my specialist in esophagus because the subject is esophagus today. So he will make nice comments. Thank you.
Okay, thank you. Okay, is there anyone who are not called your name or something?
Maybe Dr. Ishihara.
Oh, Dr. Ishihara?
Hi.
Oh,
My
thank
name
you.
is
Thank you for joining
Ishihara
us.
from Osaka. I'm very glad to attend this conference.
Okay, thank you very much. We are very happy to have you here today because today's topic is esophageal cancer. So we really hope having a very fruitful discussion today. Okay, so then we'd like to call the chair of the session, Dr. Roman from El Salvador.
Hello, Moriyama Sensei, Yao Sensei, dear faculty members. It's my great pleasure to see you again and to start our very interesting teleconference devoted to early esophageal cancer cases. But first of all, I would like to pass the microphone to our head of our department, Sergei Kashin, with the greeting words.
Dear colleagues, it's a great pleasure and honor for us to take part again in the conference. Today is very important topic for us, early esophageal cancer, and we have prepared two very interesting cases for discussion. One of these squamous cell early cancer and another one adenocarcinoma. And it's very important for us to share our experience and to ask your kind and very professional advices about the diagnosis and about the management of these cases. Both cases are very important for the Russian audience because most of the cancers, esophageal cancers, squamous cell as well as adenocarcinoma are detected too late for the successful treatment. Less than 10% of early esophageal cancer are detected at an early stage. That's why it would be of vital importance to improve the detection and management of precancerous lesions and early cancer. And thank you very much for your help and for your organizing efforts to improve the diagnosis and management of early cancer in Russia. Thank you.
Thank you very much for this very kind introduction. So let's start with our first case. Please start the presentation. The first case is early esophageal adenocarcinoma. Okay, next slide. This is the patient, male, 65 years old. During endoscopic examination, we found out the small superficial flat lesion 0 to B, according to Paris classification, in the lower part of the esophagus. You can see here the small, very small, flat, reddish area in the distal part of the esophagus. And during NBI endoscopy, we also could see small brownish flat area. Next slide. The size of this lesion is less than 5 millimeters when we applied chroma endoscopy with Lugal staining. This area was unstained and we can see the clear demarcation line of this flat lesion. Next slide, please. This is a retroflex view in narrowband imaging mode, and we can see that this flat area had the size about 4 to 5 millimeters totally flat, and we can know that we have some part of squamous epithelium between Z-line and the area of lesion. Next slide. This is the magnifying view with narrowband imaging endoscopy. We can see the irregular micro vessel pattern with irregular microsurface pattern that is corresponds to neoplastic changes. Next slide. The background mucosa of the stomach was atrophic gastritis with intestinal metaplasia in antrum and gastric body. Next slide. And the question for discussion is this small cancer is a Barrett's cancer? May I ask Moriyama Sensei and Yao Sensei to comment this question, please? What is your opinion on that?
Okay, I'd like to have a talk first. So this lesion is located on just above the esophagogastric junction, esophagocolumnar junction. So it's maybe I think it's a Barrett cancer. Okay, what do you think about it, Professor Kenshi?
So by this endoscopic finding alone, we can't make any distinct decision if this is originated from Barrett's epithelium, because this area is still covered by squamous epithelium. But just this is my imagination, but there was Barrett's epithelium and may covered by squamous epithelium after some information. So, but this is just imagination. But I can't say there is no distinct evidence this is originated from Barrett's epithelium. This is my opinion.
Thank you very much, because we also think about this, but at the time of diagnosis, we can see only flat neoplastic area surrounded by squamous epithelium. So there is no evidence that it is connected with the Z-line. So that was the main question. Is it the Barrett cancer or isolated area of adenocarcinoma? Can I ask Guido Sensei and his colleague to comment on this slide and this case? What do you think about the final conclusion, endoscopic conclusion?
Sorry, our pointer doesn't work. So, but anyway, can you hear me?
Yes, we can hear you.
So, but on the background, basically this region, because it exists in a squamous epithelium, so it is esophageal cancer. But on the background, we can see palisade vessel, longitudinal vessel. So basically, this region located in esophagus, and the image looks adenocarcinoma. So maybe same to Kenshi, probably originally developed in the esophagus as adenocarcinoma, but maybe anal side was covered with squamous epithelium. That is my opinion.
Okay.
Oh, can I ask one question?
Yes, please.
Is this patient taking some drug, such as PPI?
No,
Oh,
we
I see, I
we
see.
asked about it, but he didn't receive any anti PPI therapy before diagnosis.
Thank you very much.
Some PPI cause degenerative squamous epithelium and make something is covered. So maybe Liu mention about it.
So if he takes PPI, it is quite understandable that the anal side of the lesion is covered by squamous epithelium. But if he doesn't, I cannot explain why anal side of the cancer is covered by squamous epithelium.
Roman, do you understand the discussion? I think they think the surrounding mucosa, squamous cell mucosa, looks elevated. So maybe the lesion is maybe bigger than only 5 millimeter, but can be covered by squamous cell mucosa and hidden.
Thank you very much, Kashida Sensei. And what about further management? Should we identify the true size of the lesion with some endoscopic technologies like EUS or other technologies? How we should evaluate the real size at this case?
Maybe EUS is useful, but I'm not an expert in esophagus, so maybe you can ask Dr. Ishihara about that.
Yes, I would like to. Dr. Ishihara, could you advise us to evaluate the real size?
Maybe it is a little difficult to know the real size of this lesion by EUS. But maybe, so maybe if we use some modalities, it is still difficult to know the extent of this cancer. So maybe if I treat this cancer by endoscopic resection, I will remove large area, maybe 1 centimeter outside of the exposed area.
Thank you very much.
Can I explain? Probably Liu knows, but one Japanese doctor explained about suspicious extension, subepithelial extension is a slightly brownish area. And if we spray acetic acid, sometimes we can see small white spots, such as maybe, I'm not quite sure, like this, but some brownish area and some whitish spots are suspicious extension. But still, sometimes lesion extend more than that finding. So I'm really agree with we have to have some extra margin for the endoscopic resection.
Can I ask what you think about the depth of the lesion? Is it shallow? Is it shallow enough for endoscopic treatment?
Slightly elevated, lifting the surrounding mucosa, but the lesion is quite small and the surface structure is not really destructed. So maybe we try ESD.
You said slightly elevated lesion. What is the Paris type of this lesion according to your experience?
Maybe 2A in my
2A, not 2B, not totally flat.
because compared to surrounding mucosa, it is slightly elevated, lifting the surrounding squamous epithelium. So we classify this is 2A. I classify.
Oh, okay. Thank you. Thank you very much. Can I ask Professor Kenshi Yao about the possibility of application BS classification in this case? Is it possible to use BS classification here? What do you think?
Yes, it can be applied. VS classification is originally developed using Barrett cancer finding. So when I was staying in the UK, we have developed the original VS classification system for this. So this can be applied.
Thank you very much. And what is the description according to VS classification in this case?
Could you show me the maximal magnification?
Yes. Last slide, please. Last. Before.
This is it. So I think this is very, very focused. So individual microvessel shows irregularly shaped polygonal. So, but the heterogeneity is not so remarkable. So I will make a diagnosis. This is irregular microvascular pattern and absent microsurface pattern. So that can meet the criteria for high-grade dysplasia or early cancer. But the confidence level is low because the irregularity or heterogeneity of the microvessels is not so remarkable. So I think it's at least neoplasia, but I'm not sure this is indeed high grade or not.
Okay, thank you very much. And what did you make the diagnosis on the right image? What could you say the same by viewing the left image? Do you need high magnification for applying BS classification, or dual focus is enough for BS classification assessment?
Yes, so that depends upon the scope specification. If the scope has at least 8 micrometers resolution power, it can be applied to assess the microvascular pattern because the smallest diameter of the vessel is capillary size. The size of the capillary is 8 micrometers. So this is why we need at least 8 micrometer dissecting power. In fact, GIF 119 HQ have enough power as small as 8 micrometers. So it can be applied from the optical point of view.
Okay, thank you very much for your kind answer. Let's go forward. Next slide. Next. Next. We did endoscopic mucosal resection with CAP. And of course, we thought that it was a bit larger than we can visualize it during conventional white light endoscopy or even nerve band imaging. And we tried to capture the bigger area, and also we captured the distal part of the of this area and the proximal part of this area additionally. So we have 3 fragments: the one piece, one big fragment, the neoplastic area with marks outside of about 5 to 6 millimeters outside the visible margins, and also two samples of background mucosa at the proximal part and distal part. Next slide. This is a post-EMR histology. Next slide. The pathology histology answer, the histological diagnosis was adenocarcinoma G1, G2, and 3 without lymphovascular invasion. Vertical and horizontal margins were free of neoplasia. R0 resection. Next slide. And we noted that there were buried parts of adenocarcinoma. Neoplastic tissue was near the squamous epithelium, as we predicted and as our faculties told about. So it is really slightly bigger than we can expect, than we can absorb during the regular endoscopy. Can I ask Professor Takashi Yao to give some comments on this specimen?
Yes, I agree with the diagnosis. This is the adenocarcinoma, and is this region completely surrounded by squamous epithelium, or
yes,
yes?
Endoscopically, yes.
So if the region is completely surrounded by squamous epithelium, so I can not confirm that this region is arising from Barrett epithelium. This carcinoma may directly arise from squamous epithelial area.
This is Dr. Kensha speaking. I have one question for histological finding. Did you identify double layer of muscularis mucosa? It can be indirect findings for suggesting Barrett's previous Barrett's epithelium.
Professor Takashi Yao, can you see a double muscularis mucosa here?
No, please back to the previous slide.
Yes, please, previous slide.
So I can only see the esophageal glands. So I cannot identify the muscularis mucosa here. So, sorry. I can see the inflammatory cell infiltration here. So the muscularis mucosa must exist near around here, but smooth muscle bundle, a small amount of smooth muscle bundles here. So muscularis mucosa may distract by carcinoma. Anyway, I cannot identify the double layer muscularis mucosa.
And maybe previous slide, the overview.
So this the quality of the figure.
Oh, sorry. Yes.
So here is a esophageal gland. So muscularis mucosa must exist near here. So carcinoma may directly distract the muscularis mucosa. Anyway, at least double layers muscularis mucosa cannot be seen.
Okay, but if cancerous area invade the muscularis mucosa, there is no proof for double muscularis mucosa, isn't it? And we could not confirm the Barrett's neoplasia. Is it right? So your diagnosis here is just esophageal adenocarcinoma, not Barrett's adenocarcinoma. Am I right?
Yes, I think that this is a esophageal adenocarcinoma.
Okay, thank you. Let's go further. Next slide. Next slide. Next slide. And this is the endoscopic image, one after endoscopic resection, the retroflex view, previous slide please, and the anterograph view. As you can see, the epithelialization, we can full epithelialization of the ulcer site. Next slide. Next slide. And if we compare with the previous condition, we can see that the squamous-columnar junction bit deeper, a bit lower than the previous condition. Next slide. And this is retroflex view. We can see here the columnar epithelium here, and here we can see at this site squamous epithelium. So next slide. As squamous cell junction, squamous columnar junction bit changed, and now we can see the level of the squamous columnar junction here, and the area of columnar epithelium above the squamous columnar junction. We took biopsy at this area, and intestinal metaplasia was confirmed. Next slide. And the question is it the Barrett's esophagus? This changes. What do you think? Mariana Sensei, what do you think? Yao Sensei, Kyushu University. Is the Barrett's epithelium?
Yeah, very difficult because we can't detect parasitic vessels around here, so it's very difficult to make a definite diagnosis of Barrett's esophagus. So I'd like to ask the same question to Dr. Ono. He's a specialist of the Kyushu University Hospital.
It's difficult to diagnosis Barrett's esophagus because we can't see parasitic vessels and fold of antrum, a fold of stomach. I think, and I don't diagnose Barrett's esophagus.
So in addition, this patient also have chronic gastritis. So the intestinal metaplasia alone can predict a Barrett's esophagus. So in addition to that, the real resected specimen does not show any evidence for Barrett's. So we can't say it's Barrett's origin. So this is only thinking of ours.
Okay, thank you very much. Ueda Sensei, Osaka Institute, could you give some comments on the situation?
Same comments, no additional comments.
Okay. Thank you. Next slide. This is the endoscopic image 6 years after endoscopic resection. Next slide. So now we have the tongues of columnar epithelium in the distal part of the esophagus. Next slide. This is the retroflex view. We can see the scar scarring the cardia region. Next slide. And if we compare with first endoscopic examinations, maybe we can see that the width of the squamous area slightly changed, slightly decreased. Next slide. And we measured the size of these tongues. The size was more than 1 centimeter, and the confirmation of intestinal metaplasia we also have got. Next slide. And the question for discussion: what is it the progression of the metaplastic changes, and is it Barrett's or not in this case, and what is the further management of this situation? Follow-up, endoscopic resection of this area without the absence of confirmation of neoplasia, just intestinal metaplasia, or maybe endoscopic eradication of the mucosa, like we did in Barrett's esophagus after endoscopic resection of Barrett's neoplasia. Kyushu University, Ryama Sensei, Yao Sensei, what do you think about these changes?
Okay.
Is it still benign, or we should do something else?
Okay. If I were you, I will just follow up this patient because it's very difficult to make a definite diagnosis based on only this photo. Because I look a bit in whitish or bluish. I'm not sure, but I suppose that there may be an intestinal metaplasia or something around there. But actually, there is no finding suggesting malignant lesion. I'm not sure, but no treatment, additional treatment seems to be needed for this patient, for this case, I suppose.
Yes, I have the same opinion. Probably I will follow up this patient using magnifying endoscopy. So it can give us some suspicious area for targeting just biopsy. So that should be enough. So this is my opinion.
Thank you very much. And what do you think about, what is your opinion on the management strategy in general in Japan? If Barrett's neoplasia has been removed, what the further management of the Barrett's esophagus? Should we eradicate with ablation technologies? Is it, what about the Japanese standards?
You can comment.
Maybe for small segment Barrett esophagus, we don't treat, we don't eradicate such mucosa. But for long segment Barrett esophagus, some doctors say that they should eradicate the mucosa. Okay.
Thank you, Chikara-sensei.
Because I think the risk of Barrett esophageal cancer developing from this small Barrett esophagus is very, very low. So just follow-up is a common treatment follow-up strategy in Japan, I think.
Okay. Thank you very much. Thank you. Sensei, would you like to give some more comments?
No, same opinion. But still, prevalence of Barrett esophagus in Japanese population is quite low. So still practice is not yet well standardized. But anyway, we basically follow similar to Western guideline. Even Western guideline, maybe only partial Barrett's smaller, shorter than 1 centimeter, usually just follow up. No eradication, I think.
Thank you. Thank you very much. Next slide. Actually, the question was ablate or not to ablate in this case. And when we found out that the columnar epithelium was bit more than 1 centimeter, that we have confirmed intestinal dysplasia. It was diagnosed. The Barrett's esophagus short segment was diagnosed, and according to history of early esophageal adenocarcinoma, multidisciplinary team recommend to eradicate even maybe small cancer risks. The multidisciplinary team recommended to eradicate with ablation technologies, and we make ablation of this small Barrett segment, this segment of columnar epithelium with the hybrid APC. So that is the final slide, and we are waiting for epithelialization of the post ablation, post-ablative ulcer, and we in the near future we will check the patient about epithelialization of this ulceration. And some comments from Sergei Kashin.
Dear colleagues, thank you very much for your kind comments and advices, because it's very important for us to understand what's really happened in the distal esophagus. And it's important for us to understand that this is not Barrett's lesion, that it was esophageal adenocarcinoma. Sometimes it's difficult to differentiate esophageal adenocarcinoma from Barrett in the distal part of the esophagus because of PPI treatment. And actually, we thought that we did not exclude that this lesion was a Barrett lesion. But now we clearly understand this. So I am very happy that we have a chance to discuss in details this case. It's very, very important. Thank you.
Thank you very much, dear faculty, dear colleagues. Thank you very much for your very nice discussion. Let's go further to our second case. This is another case, the case of squamous cell cancer with another localization. The location of this lesion was upper part of esophagus. Okay, thank you. Next slide. This is the case of 58 years old male patient with a superficial flat lesion of the upper part of the esophagus. You can see a small reddish area, flat area, the size about 5 millimeters, and during nerve band imaging endoscopy examination, you can see the brownish area of the background of greenish squamous epithelium. Next slide. This is the nerve band imaging endoscopy. We can see the slightly increased capillary pattern at the proximal part of the lesion. Next slide. With the magnifying view, we can see that in the central part there are some irregular ICPLs. Next slide. This is the central part with with local changes of ICPL. Next slide. And the distal part, the end of the distal end of the lesion. Next. So the question for discussion, for our discussion is, what is the type of IPCL? What is predicted histology of this lesion? And what is further management? University, Yao Sensei, Moriyama Sensei, what is your opinion?
Okay, I will ask my colleagues who is specialized in esophagus. He's the expert.
Yes, please, thank you.
I think the region and the type of IPCL of the region is B1 vessel at Japanese Esophageal Society guidelines. で、スライド1個ももう一個。And I think the best seller is a vascular area. We can see. Ah, いいです。その前、次ですかね。もう一個前です。これでいいです。I think this area is a vascular area. Is small. And the type of IPCL is B1 vessels. I think squamous cell carcinoma. And I think the region is depth of invasion is lamina propria vascular LPM layer. And I planned the endoscopic resection.
Okay, thank you very much. I noted that Kashida Sensei make a point on our endoscopic image. Kashida Sensei, could you comment your points?
Yeah, I agree with the previous doctor. So I indicated the small avascular area with the line. Am I correct to show small avascular areas like this?
Okay.
All right. So I'm not a specialist, but I agree to the previous doctor about the avascular area.
Okay, thank you very much. Can we go another slide? Last slide, previous slide, previous slide, previous, please. Previous. Yes, this one, please. Can I ask our faculty about these changes? What do you think about these changes of microvasculature? Is it neoplastic changes or something else? What is your opinion, please, Kyushu University?
Can I comment? So I think this is really periphery. Probably slightly depressed area is a cancerous epithelium. But this is really periphery or almost outside of demarcation line. So it can be inflammatory because the bit elongated, but not really tortuous, and the caliber change is not so obvious. So almost like a similar direction, and the arrangement is bit homogeneous. So But anyway, if we treat this lesion, we include this area. But anyway, it could be some inflammatory change on the periphery of the neoplasia. That's my comment.
Okay, thank you very much. Next slide. Next. Next. And of course, we totally agree with our faculty colleagues that we need to reset this area. We choose the very difficult location of this area, and we choose hybrid EMR. We use dual knife for semi-circumferential incision at the anal side of the area. And after that, next slide, we made a resection with the cap. We resect this area with one piece. You can see the post-TSD, post-EMR ulcer, and post-EMR specimen. Next slide. And the post-EMR histology was esophageal squamous cell cancer G2, invasion into muscularis mucosa without lymphovascular invasion, and it was R0 resection. Next slide. At the background mucosa, there were the signs of viral esophagitis. Could I ask Professor Takashi Yao to make a comment on this histological picture? Do you agree that there are some signs of esophagitis, some maybe viral esophagitis?
So I don't think the viral infection, this series just shows regenerative change. Both nuclear slightly enlarged. But I cannot find any finding of viral infection.
Okay, but just esophagitis.
Yes.
Mm-hmm. So this it is the area that we discussed before with Ueda Sensei, some elongated IPCLs with a relatively regular shape that corresponds to esophagitis. So we found esophagitis at the background of this lesion. Okay, next slide. So 1 month after endoscopic resection, we can see the total epithelialization of the ulcer area. Next slide. And of course, it is very difficult location as for diagnosis and as well for treatment. At this area, we frequently diagnose the inlet patch lesions. And according to quality standards of British Society of Gastroenterology, the presence of inlet patch should be photo documented, and the inlet patch percentage, the diagnosis percentage could be also the one of the quality indicator, because the detection of inlet patch can be used as a surrogate marker of careful examination of the esophagus. So the final question is for our faculty, how we can improve our detection, the detection of these small lesions in this difficult location. Should we use CAP? Should we use the observation during withdrawal phase? Should we use NBI obligatory during inspection of the esophagus? What is your recommendation to careful of the esophagus and the area of upper esophagus. Kyushu University would you make some recommendation for us? Moriyama Sensei.
Can I comment? Maybe usually in our practice we usually use CAP for screening examination. But a CAP is really helpful to see the upper sphincter. But otherwise, maybe we just carefully withdraw with slight insufflation or something. But maybe inlet patch could be good surrogate marker for good standard observation.
Sensei, and the question is, should we start with NBI mode to for examination? Like there are some recommendations from Japanese experts to do that. Would you recommend to do it routinely?
So if we pick up squamous cell neoplasia, NBI, there's a randomized control trial shows that a significant benefit. So if we focus on detection of squamous cell neoplasia, I think it's better to observe one direction with NBI and another direction with white light observation. I think so.
Thank you very much. We think that this is very, very important case especially for the young doctors, because it's of vital importance to detect cancers and any neoplastic lesions in the upper part of the esophagus, because it's some of these lesions could be missed during upper GI endoscopy, especially in case of examination without sedation. And that's why it's very important to detect all of the lesions and all of the changes in this part of the esophagus, for example, inlet patches. So I think that this demonstration is very, very important for all of us, and because it's just a few cancers, such kind cancers are detected in Russia in this area at an early stage. For us, it's also a great experience because we have just a few cases like this. Thank you very much for your kind comments.
Thank you very much. It was the last case. Moriyama Sensei, thank you so much for this very nice, fruitful discussion, for every faculty, for every participants. Can we finish our session?
Yes, okay. Thank you for good sharing as usual, Roman. Today's topic was esophageal cancer, and we really enjoy the discussion. And I suppose that these kinds of fruitful discussion can contribute to your daily practice. So thank you again for your participation in this very difficult situation. And also, we really appreciate to Dr. Ono and Dr. Ishihara and also Dr. Kashida to join us for the first time. So next time that we would like to have more fruitful discussion on various topics on gastrointestinal diseases. So we really hope to meet you all again. And I suppose the next date will be announced after discussion with Roman and other experts. So please stay safe and see you again. Thank you for joining us. Bye.
Bye.
Thank you.
Please answer the questionnaire, please.